And we are live now.
Yeah, thank you, Isika. So good evening and welcome you all for this API-ICP postgraduate training session. This evening we have with us Dr. Yuvraj Muruganandam, Professor of Medicine from Government College, Department of Medicine. Welcome, Dr. Yuvraj, for this evening and thank you for accepting our invitation.
Thank you,
And we
sir.
have, yeah, and we have with us Dr. Sadish Kumar, the Assistant Professor of Neurology, with us. Really, thank you, sir, and welcome you for this evening.
Good evening, sir,
And
and thank you.
yeah, good evening. And we have with us Dr. Mala, the postgraduate from Cornell College, Department of Medicine. Welcome, you, doctor. And over to the faculties and the postgraduate to take over further proceedings of this session. Please.
Okay. Good evening, sir. Myself, Dr. Mala, third year postgraduate from Coimbatore Medical College. Today I am going to present a case of CNS case presentation. Mr. Murugan, 65-year-old male, working as a gardener, presented with the chief complaints of difficulty in using both hand for past 1 year and difficulty in walking for past 9 months and difficulty in speech for past 2 months.
Mala, you mean difficulty in using the hand? Did he is not able to do the skilled work, or it is not able to lift the
not able to do skilled works.
works? But he is able to perform the daily activities, other activities. He is able to lift.
Yes, sir. He is able to perform daily activities.
Okay. Okay.
Patient was history of present illness. Patient was apparently normal 1 year back, after which he developed weakness of left upper limb, followed by right upper limb in the form of holding an object with his hand, and history of difficulty in buttoning and unbuttoning of his shirt, and history of difficulty in mixing food, and history of difficulty in lifting heavy object with the hand, which was insidious on onset and gradually progressed over a period of 1 year. No difficulty in moving the hair, no difficulty in raising the head above the hand above the head, and he also noticed left lower limb weakness followed by right lower limb weakness for with a span of 2-month period in the form of tripping up toes and slippage of the slipper while walking, which was insidious onset and gradually progressive over a period of 9 months. He also
Okay,
had
so the progression of the disease is asymmetrical. It is not symmetrical.
Yes, sir. It is asymmetrical, sir. Mainly started distal movements.
Okay.
Then instead of difficulty in heading up from the sitting and squatting position is present. Instead of difficulty in climbing in the stair, he used to climb the stair with the support of the person, and no instead buckling of knee, and no instead difficult in turning side to side in bed, and no instead difficult in lifting the head from the pillow. And instead of thinning of muscles in the
what do you want to infer, Mala, with no buckling and turning side to side and lifting the head? What do you want to infer from this?
Sir, buckling of knee, it's element involvement. The patient will have loosening of the limbs, sir. When stand up, the patient will when head up, when patient was stand up, the knee will be loosening and the patient will not able to get up, sir.
He's not able to use his knee to get up from the squatting position. Okay.
Yes, sir. Instead of thinning of muscles in both and present for past 2 months. He also noticed involuntary twitching movements over both arms and forearms for past 2 months. And no difficulty in breathing. No sensory disturbance. Patient was able to feel hot water, cold water while bathing, and patient able to feel the presence of cloth all over the body, and is able to feel the bite of insect and pinching sensation, and no tingling or numbness, and no swaying while washing the face with the eye closed, and no swaying while walking with the eye closed, and no electric shock like sensation on bending the neck, and is difficulty in speech for past 2 months. No headache, loss of consciousness, memory disturbance, emotional disturbance.
Excuse me, can you elaborate the difficulty in speech?
Sir, patient have difficulty in speech in the form of nasal twang, sir.
Is it fixed or it is modulate? He is able to modulate or it is fixed? There is any modulation?
He is able to modulate. Modulation of voices, sir. Yes, sir.
Okay.
no headache, loss of consciousness, and no memory disturbance or emotional disturbance, no difficulty in appreciating smell, no blurring of vision or loss of color vision or double vision, no difficulty in eye movement or drooping of eyelids, and no difficulty in chewing food, and no deviation of mouth or drooling of saliva, and no loss of taste, and no hearing loss, ringing sensation here, and no nasal regurgitation of food or difficulty in swallowing or coarseness of voice, and no difficulty in turning head from side to side, no difficulty in protrusion of the tongue, no difficulty in making food bolus or marshalling of the foot, and no difficulty in negotiating through narrow pathway, and no fullage of food while eating, and no tremulous of hand or head nodding. He was
Okay,
able
sure
to
that
perceive the
you are sure that he is able to protrude the tongue and able to chew the food properly and swallow.
yes, sir.
Okay.
He was able to perceive the bladder fullness and able to hold the urine, and no increased urge to void, and no feeling of incomplete evocation of the urine after voiding, and no difficulty in initiation of urine or tripling of urine, and no fecal incontinence, no giddiness, palpitation, reduced sweating or skin changes, no slowness of activities, no reduced facial expression, no involuntary movements of the limb, and no recurrent falls, and no fever, weight loss, loss of appetite, and no vomiting, loose stools, and no chest pain, no skin rash or joint pain, or no cough with expectoration, and no trauma. And past history, he was known case of old pulmonary tuberculosis, 20-year backs, and completed full course of ATT. And known case of CAD for past 2 years on under treatment. Not a known case of diabetes mellitus, hypertension.
What are all the post TB CNS sequelae do you expect?
Patient TB meningitis or tuberculoma or spot spine or kippus.
Okay.
No drug intake or a toxin exposure, no recent COVID vaccination or a dog bite. Personal history, he consumed both veg and non-veg diet. Adequate sleep. Chronic smoker, started at 20 years of age, 1 pack per day, and quit smoking for past 24 years. Not an alcoholic. Married and had 3 children. Family history, no similar complaints in the family members. And treatment history, has not taken any treatment for present illness. The patient was known case of CAD, so he taking tablet aspirin and atorvastatin. Summary. 64-year-old male, known case of CAD, admitted with the instance onset gradually progressive asymmetrical weakness of all 4 limbs with dysarthria, with muscle twitching and thinning of the bilateral upper limb, with apparently normal higher mental function, sensory system and cerebellum and autonomic system. The probable structure involved bilateral corticospinal tract and bilateral anterior muscles.
Okay. There is no changes in the tongue.
The history-wise, no changes, sir.
Okay.
And differential diagnosis, cervical compressive myeloradical
upper motor neuron lesion.
Sir?
Why you think it is upper motor neuron lesion?
The patient will have distal movements, skilled movements, fine, skilled and distal movements will be affected in both hands. So, and
how will you differentiate upper motor and lower motor neuron lesion by history?
In upper motor neuron lesion, the patient will have history of heaviness of the limb, sir. In lower motor neuron, the patient will have looseness of limb or the flyness of the limb. And in upper motor neuron lesions, the fine and skilled movements will be affected, sir. In element, either one distal movements will be affected, sir. Either one muscles group will be affected.
Very good. In upper motor neuron lesion, there is a paralysis of movement. In lower motor neuron, there will be paralysis of individual muscles or group of muscles.
Yes, sir. Okay.
And the LMN is associated with the thinning of muscles.
Yes, sir. Muscles and humans, there is no wasting and
maybe delayed wasting may be there. So in this patient, you are having a thinning of muscles and twitching of muscles.
Yes, sir.
Why
And
you are not involving a lower motor neuron lesion?
sir, lower motor neuron thinning and wasting mainly anterior horn cells involvement, sir. But patient
very
have
good.
skilled movements activity will be involved, sir. So the upper motor neuron also involved.
Yes, very good. We have both upper motor and lower motor neuron
Anterior
involved in this patient.
yes, sir.
Purely motor system. It's not a sensory system involvement as per history.
Yes, sir. Purely motor, sir.
Bladder bowel not involved.
No involvement. Yes.
Only speech is getting involved.
Yes, sir. Speech only it's involved.
That too in later phase, dysarthria and later phase, right?
Yeah, after past 2 months only. It has
Past 2 months only.
Yes, sir.
Okay.
I would like there's a differential diagnosis: cervical compressive myeloradiculopathy and craniovertebral junction anomaly and motor neuron disease and multifocal motor neuropathy with the conduction plaques or hyperthyroidism. So in this patient, for history wise, it doesn't have any cranial lower cranial involvement. So cervical compressive myeloradic and no root pain, sir. So we exclude the diagnosis. And
we cannot
craniovertebral
exclude
junction
that.
anomaly.
We
Okay,
cannot
sir.
exclude the diagnosis. The probability in the
Okay.
list is comes down.
You
Okay,
can prioritize your diagnosis. You can prioritize.
Okay. Okay, sir.
So what is the against point in compressive myeloradiculopathy? Yeah.
The patient will have the root pain will be there, sir. And at the level, the patient will have element lesion, and below the level, patient will have human findings.
Another
Speech is
important
getting involved.
speech is not another one important is sensory
Speech is not involved. Sensory system also it's involved in compressive
at the
myelopathy.
level of lesion. Yeah.
And there is no radicular pain in this patient.
It's no root pains.
No radicular pain. So these are the odd
Yes.
points thing like
So,
cervical
against the
compressive myelopathy in the lower down in the order of the list.
Okay, sir.
Any other disease will have the same upper and lower motor neuron involvement sequentially together?
One the higher cervical cord compression, sir. And the motor neuron disease with the ALS and cervical compressive myeloradiculopathy and thringomylia, sir.
So why you think motor neuron disease? What are the points favoring motor neuron disease?
The patient will have both human and element weakness, both human findings and element weakness. Thinning and wasting or fasciculation is there, sir. So it's a favor of element, and fine distal skilled movement will be affected, which is favor of human, sir. So and the dysarthria also is there, sir. So which include bulbar involvement. So patient will have both human and element and bulbar involvement, sir. So which favor motor neuron disease.
Which is the commonest sex to have motor neuron disease? What is the age group? Commonest age group for motor neuron disease?
Male predominance are mainly, and my age group mainly peak 65 to 75 years, sir.
No, the male to female ratio is 4:1, as you said, but the age of occurrence starts from 35. And in India, and in
35 to
India,
50, but peak incidence will be 65 to 75
yeah,
years.
yeah. In India, it will be earlier. As per
Okay,
Western, in India, it will be earlier. So
Okay, sir.
it will be the beginning. It will be in the third decade. So it is not in the sixth
Okay,
decade. Maybe the peak may be in sixth decade. Okay.
Okay, sir.
You can proceed, pa. Certainly proceed.
Yes, sir.
Okay.
Multifocal motor neuropathy with the conduction block. Why you think that?
So the patient will have element the element fasciculation and thinning of muscles with the weakness, sir. So element in multifocal motor neuropathy will be patient present like element features, sir. So I think of
Okay.
Point against
In this,
a patient point against the patient will have human, sir. In multifocal motor neuropathy, only element will be affected, sir. And human mostly not the
you won't
rats.
get twitchings over the arm region.
Okay.
because of his smoking habits and because of the age, can we think of paraproteinemias and paraneoplastic syndromes?
Sir, paraneoplastic also is there. Paraproteinemia or a small cell carcinoma of the lung may be one of the differential types.
We can think of that also, right?
Okay, yes, sir.
Because they will present directly with the paraneoplastic syndrome rather than the primary sometimes.
Yes, sir.
Okay.
Okay. Yes, sir.
Proceed, Pa. You proceed.
General examination. Patient is conscious, oriented, moderately built and nourished, height 160 centimeter, weight 68 kg, and BMI is 24.6, not pallor, not ecteric, clubbing present, grade 2, known cyanosis, no pedal edema, no generalized lymphadenopathy, height and neck ratio 12.5, skin and appendages normal, no facial asymmetry, no hair or no discharge from the eyes, no rash, no neurocutaneous markers, no cutaneous markers, external cutaneous marker of tuberculosis and HIV, and no peripheral nerve thickenings. And vitals,
you know, doesn't notice any facial asymmetry in this patient?
No, sir.
Okay. Okay, Pa.
Pulse 92 per minute, regular rhythm, normal volume and character, felt equally in all palpebral peripheral vessels, no radio delay and no radiofemoral delay, and condition of the vessels all are normal. Blood pressure 110 per 70 millimeter mercury, measured in right upper limb in supine position, respiratory rate 18 per minute, abdominal thoracic type. Nervous system examination, higher mental function examination, patient conscious, oriented to time, place, person, right-handed individual, uneducated, and memory, immediate reason and remote memory was intact. Speech in dysarthria, sir, the placid dysarthria normal, comprehension normal, and naming normal, writing and reading could not be done. Cranial nerve examination, olfactory nerve, patient able to perceive smell normally in bilateral nostril. Optic nerve, visual acuity 8 per 6, visual acuity 8 per 16 on both eye, 6 by 18 on both eye. Field of vision normal on both eye, color vision normal on both eye, and fundus examination of third, fourth, and sixth. The extraocular movements are normal on both sides. No nystagmus, and pupil size 3 mm, reacting to light, and pupillary reflex are present on both sides. Accommodation reflex are present on both sides. Trigeminal nerve, sensation over the face, present on both sides. Muscles of mastication, normal on both sides, and corneal reflex, conjunctival reflex present on both sides. Jaw jerk absent. Facial nerve, the ringling over the forehead present on both sides, and closing of eye against the resistance present on both sides, and nasolabial fold normal on both sides, no deviation of angle of mouth, able to close the cheek and whistle. Taste sensation over anterior two-third of tongue normal on both sides. Vestibular cochlear nerve in the eighth nerve. The Rennes test, air conduction is better than bone conduction on both sides. Weber test, no lateralization. And claustropharyngeal and vagus nerve, uvula midline, hack reflex normal, palatal movement normal. Spinal accessory nerve, the patient able to struck the shoulder against the resistance present on both sides, and turning head sideways against the resistance on present on both sides. Hypoglossal nerve, the patient have tongue atrophy and tongue fibrillation and no deviation of the tongue, and able to protrude the tongue present and tongue movements normal. Motor system examination, inspection, wasting of bilateral thenar and hypothenar muscles present. The wasting is more predominant on thenar compared to hypothenar in both hands, and fasciculation present in right upper arm, medial and lateral aspect, left upper arm and medial aspect, and right forearm just below the elbow joint and both thigh. Motor system examination, bulk 10 centimeter above the 10 centimeter bulk, arm circumference 10 centimeter above the medial condyle, 26 centimeter on right side, 25 centimeter on left side, and 10 centimeter below all forearm circumference 10 centimeter below olecranon, 24 centimeter on right side, 23 centimeter on left side, and thigh circumference 18 centimeter above the patella, 39 centimeter on right side and left side 39 centimeter, and leg circumference 10 centimeter below the tibial tuberosity, 33 centimeter on both sides. And tone, upper limb normal on both sides, lower limb hypotonia on both sides. Power, shoulder joint, flexion, extension, abduction, adduction, internal rotation, external rotation on both sides 4 by 5. and elbow flexion and extension 4/5 on both sides, and wrist palmar flexion, dorsiflexion, hand 4/5 on both sides, and hand grip weak on both sides. Hip flexion, extension, abduction, hip flexion and abduction and adduction 4/5 on both sides, and extension 3/5 on both sides, and knee flexion, extension 4/5 on both sides, plantar flexion 4+ on both sides, and dorsiflexion 4+ on both sides. External hallucis longus weak on both sides. Reflexes, superficial reflexes, corneal reflex, conjunctival reflex present on both sides, abdominal reflex absent on all 4 quadrants, and chromastic present, and pulbocavernous present on both sides. And plantar no response on right side, and extensor on left side. Deep tendon reflex, biceps 3+ on right side and left side 2+, and triceps reflex 2+ on right side, left side 2+. And
Mala, you told
brachioradialis,
you told the tone is normal.
tone
limb.
is normal on upper limb, sir, and lower limb is
And the reflex
kyphotonia.
is brisk. Huh?
Yes, sir.
The tone is normal, but the reflex are brisk.
Yes, sir.
Okay.
Knee jerk 2+ on both sides, angle jerk 1+ on both sides, palmomental reflex absent on both sides, clubular tap, clubular reflex absent, and snort reflex absent on both sides. On sensory system, pain and temperature, joint position, vibration, fine touch, all modality of sensation intact, and Romber test negative. Cortical sensation, tactile localization, 2-point discrimination, stereogenesis, cryptopsia, normal. And cerebellum, finger nose test, normal on both sides, and finger nose test, normal on both sides, and no dysthyrokinesia on both sides. Heel chin test, normal on both sides. No nystagmus, no scanning or staccato speech, gait normal, no extrapyramidal signs. Spine and cranium, no hyposis, no scoliosis, and cranium normal, no signs of meningeal irritation. Other system examination, cardiovascular system, S1, S2 heart, no murmur, respiratory system, no normal vesicular breath sound, heard over the both lung fields, no added sound, abdominal examination, soft, no non-tender, no organomegaly, bowel sounds are normal, and parietal examination normal. Summary, 65-year-old male, known case of CAD, admitted with the initial onset, gradually progressive, asymmetrical, plastic quadriparesis with the flaccid dysarthria, with the fasciculation, with wasting, and bilateral upper limb with apparently normal higher mental function, and sensory system, cerebellum and autonomic system. The probable structure involved motor weakness, bilateral corticospinal tract, above C5 and below C3 level, and reflex level at C5, and wasting and fasciculation, so LMN, cervical and lumbosacral segments, and flaccid dysarthria, so bulbar involvement, 12th nerve pulse.
So what's your probable diagnosis?
So motor neuron disease, sir.
Motor structures involved are corticospinal tract, anterior horn cells, right?
Sir.
In cervical and cervicodorsal and lumbar.
Lumbosacral regions.
Lumbosacral stage. So what are all the types of motor neuron disease there?
Motor neuron disease, progressive primary lateral sclerosis, amyotrophic lateral sclerosis, progressive pulpar palsy, progressive spinomuscular atrophy, and pseudobulbar palsy.
Which of these are human, which of these are LMN, and which is combo of LMN and human?
Amyotrophic lateral sclerosis, both human and LMN involvement will be there, sir. And human primary lateral sclerosis, pseudobulbar palsy, and LMN progressive spinomuscular atrophy and bulbar palsy, sir.
Here, what will happen if the motor neuron degeneration is there? It is replaced by which protein?
Sir, it is replaced by lipofusins and neurofilaments.
What will happen then?
After that, the microglial and astrocytes are proliferated, which is replace the cells.
Okay. Which is the first group of muscles to involve?
In hand, it will be thenar muscles will be involved, sir.
Okay. Which group is last involved, or what is called ultimomoresis?
Timomoresis, the patient rhomboids major involvement will be later involvement, sir.
Which myotome?
C5 myotome, sir.
C6. C6 myotome.
C.
It is C6
Okay.
myotome. What are all the characteristic features of MND from examination?
MND will have patient will have progressive asymmetrical distal
Asymmetrical
weakness.
type.
Yes, sir. Distal weakness more than proximal weakness, and wasting more than weakness, sir. With both human and element involved.
Okay. Fasciculation and hyperirritability of the muscles one of the characteristic point, and the unmodulated nasal voice is another one of the, because of the lower cranial involvement. Unmodulated nasal voice is one of the characteristic of MND.
Okay, sir.
Okay. How will you assess the disease is worsening? What are all the neurological markers to say, or neurological signs to say the disease is worsening?
This is epicutine.
When the patient is starting aspirating,
Respiratory muscle paralysis or nasal bulbar involvement progress to this
that indicates the disease is worsening.
Yes, sir.
Any treatment modalities available for this disease?
Sir, treatment modality mainly for supportive treatment, sir. We can give a releasol and edaveron.
That's all.
Sir, mainly supportive
not
therapy
proven
only, sir.
therapies.
Sir,
So far nowadays there is no proven therapy to
yes,
say
sir.
that
Only
we can
supportive
treat
care.
this.
No, sir, we can't treat, sir. Only supportive therapy is the mainstay of treatment.
See, our aim is to maintain the nutrition of the
This
patient.
is okay, sir.
So as far as the nutrition is okay, patient is doing good.
Yes, sir.
So in order to improve the nutrition, what step you will take, at what time you will take?
Sir, if patient have any nasal dysphagia, we can give gastrostomy, sir.
In percutaneous gastrostomy, we can put a big tube inside his stomach so that we can feed the patient. As far as the patient is concerned, the gut is working well. Only thing swallowing is the problem. So patient himself, they can prepare their food by themselves. They can grind the food, they can grind the tablets, and they can feed the tube by themselves. I have seen patients. I've seen patients, those who are all preparing food for themselves in the household.
Yes,
they are walking in or around with gastric feeding tube.
Yes, rice to feeding.
In their life independently, somehow, for some time being.
Okay, sir.
One question, what is Madras motor neuron disease?
Madras motor neuron disease. There is a group of young individual affected in Madras with the wasting and muscle weakness, fasciculation, sir. Mainly the patient will have sensory neural deafness, sir.
Deafness, associated with sensory deafness. Okay, sir. Any other questions, sir, for discussions?
See, what else you will think in this patient? The motor neuron disease, it's a degenerative condition. Yes, we discussed in the history. Yes, Yuras has said we have to rule out the paraneoplastic etiology in this patient. Because you said there is a clubbing in this patient, chronic smoker history. We have seen in our ward in 2 cases proven to have cancerous etiology, malignant etiology in patient presented with motor neuron disease.
Okay. We can.
You have to completely do a cancer screening also, right? For
Yes,
to
sir. Yes,
route
sir.
any
Chest
paraneoplastic and
X-ray.
also paraprotein. Yeah, paraprotein nursing.
Yes, we can do for
Okay.
chest X-ray and serum calcium and parathyroid level and thyroid status, sir. And
Can we do
and
any rehab? Can we do any rehabilitative measures?
sir, in case of foot drop, we can give splint, sir, splint therapy, ankle splint, or in case of finger drops, we can give finger splint, or patient and speech therapy also we can give, sir. And in nutritional, we can give gastrostomy or rice to feeding. And
So why you say it is amyotropic and lateral sclerosis? What do you mean that?
amyotrophic means the atrophy of the muscles, sir. And lateral
Very good.
sclerosis means the cortical spinal tract will be affected. The motor neuron cells will be affected and will gone into sclerotic changes, sir.
Astrogliosis
scarred.
astrogliosis
Lateral part of the spinal column gets scarred.
Yes,
So
sir.
let us say it is called the
Sclerotic
lateral
changes.
sclerosis.
Yes, okay, sir.
Okay. So shall we finish, sir?
Yes, sir. How to proceed, sir? Further investigations.
Sir. Patient, we can do complete blood investigation, sir, and to look for any infection, total count, and HP level, and a platelet, and MCV for in vitamin B12 deficiency, and any inflammatory disorder. Yes, sir, we can look for, sir, and viral markers, and HIV. We can do, and RFT in case of plasma cell dyscrasis we can expect, sir, and LFT. We can proceed with the thyroid function test, and VDRL and chest X-ray and serum calcium and CSF analysis, sir, and MRI brain with the whole spines.
Okay, but if you are given a chance to do nerve biopsy or muscle biopsy or nerve conduction study or EMG, what will you prefer in this patient?
EMG, sir.
Why?
In EMG, the muscle EMG, we can look for any fasciculation or fibrillation spontaneously, and also there is a requirement reduced in EMG will be muscle fiber, and also action potential change.
See, in EMG, we can prove the LMN findings.
Okay, sir.
Human finding, we are having 4 regions: cervical, thoracic, lumbar, lumbosacral, and cranial. Okay, for cranial part, we have bulbar weakness, tongue atrophy, wasting, and if we are able to elicit the upper motor neuron signs in the cervical region or in the cranial region, either by means of facial reflexes or a brisk jaw jerk, that correlates for a UMN sign and an LMN sign in one region. And you are able to demonstrate the fasciculations and brisk reflexes in the upper limb, that's called cervical region, that's one region. And you are able to demonstrate the brisk reflexes. In this patient, we are not able to see the fasciculation in the lower limb. So by means of doing an EMG in the lower limb, vastus lateralis muscle, we can demonstrate the fibrillation potentials in the insertion phase and the resting state. So that indicates a LMN lesion. Okay, and we can demonstrate chronic denervation also in this patient. So that correlates with the 3 regions involving both LMN and VMN that fulfills the definitive criteria for the ALS. What is the criteria called?
LS score criteria, sir.
LS score criteria. Can you enumerate that?
In LS score criteria, the clinical pictures, the patient will have progressive weakness of both upper motor neuron and lower motor neuron involvement involving the bulbar, cervical, lumbosacral or thoracic segment. In definitive criteria, the patient will have either 3 of the segment will be involved in the 3 or more involvement, and if it is probable it is two, any two of the segment will be involved, and possible means it one of the segment will be involved, sir.
It's very good. So we go by the criteria for diagnosis of this motor neuron disease.
Yes, sir.
Yes. So and one more criteria is there, Avaji's criteria. That we may not be able to. Avaji criteria.
Yes, sir.
That's okay. If you not remember, that doesn't mean that. One thing we can remember is L as Corel criteria.
Okay, sir.
So we tend to do nerve conduction and EMG for this patient. Suppose if we want to demonstrate, we can demonstrate tongue fibrillations by means of doing glossopharyngeal muscle EMG.
Yes.
By placing a needle below the mandible, we can reach the tongue muscles and we can demonstrate the vesiculations, fibrillations in the EMG.
Okay, sir.
So how are you going to counsel the family members?
Sir, family member.
What are all
the prognosis?
warning signs, or what are all the awareness should be given?
Sir, patient will go for aspiration, sir. So to prevent aspiration, you can give, if in any case of cough or any regurgitation is there, sir, and its symptoms was worsening. So and it's a bad prognosis. The life expectancy will be 3 to 5 years, sir.
Any simple test can be taught to them to assess the respiratory embarrassment. Any simple test.
Single breath count, sir.
Very good. Single breath count should be taught to the patient. Certain test.
Okay, sir.
And while patient visiting to you, you can measure the forced vital capacity. FTV, forced vital capacity, you can measure in the hospital if the patient comes and meet you.
Okay,
you can document it, and if the patient worsening, you can warn the family members. This patient is worsening, and you can proceed next step. We can go for intermittent non-invasive ventilations also in the night time in order to improve the respiratory function.
Okay, sir.
So how long they will survive?
Sir, mostly in 1/3 of patient will be like expectancy 5 years. Sir.
Usually around we say it is 3 to 5 years they can
3
survive.
to 5 years. Yes.
Usually, generally we say.
Okay.
See, the role of the physician in this patient is diagnosis is establishment is not a big task for us. We have to rule out the secondary cause, hyperthyroidism and paraneoplastic and any other treatable condition that patient is having. And supportive treatment.
Hyperthyroidism and paraneoplastic.
And we have done an MRI to rule out a structural lesion in the craniovertebral junction. So these things we have to must do, and we have to do VCTC. That means the retroviral status of the patient. That
and
can mimic anything.
Yes,
Still late, the patient may not have a bladder bowl involvement or ocular movement involvement. In a very advanced disease of the patient, only they can have extraocular movement restriction and bladder bowl involvement. If you see the advanced disease of patient, they used to have these things very late.
Okay.
Okay, sir. Okay, sir. Saravanan?
Yes, Raj.
Saravanan? Let me conclude the session.
Yeah, but there's no other points we can conclude.
Okay.
Okay.
You want to add some more, Saravanan? Okay.
Thank you, congratulate the presenter. Thank you, sir.
Thank you.
And I want to thank you, dignitaries. I want to congratulate the presenter for taking steps to present this case. And I want to thank the Department of Medicine in Coimbatore Medical College Hospital for allowing me to present and participate in the discussion. And thank you, Ura sir. Thank you, Sukma sir. Thank you, sir.
Thank you, sir. Thank you.
Thank
Thank you.
Thank you.
Thank you.
Congrats, Mala. Thank you. Thanks a lot.
Thank you, sir. Thank you.
Thank you, sir.
Thank you. Okay, sir. We'll close the session.